Okay, so I'm just going to give you a little talk about Horner syndrome. So, as you know, Horner syndrome is due to a lesion of the ipsilateral oculosympathetic way, and this sympathetic pathway has a big part in the innervation of the sweat glands, which means face sweating, iris dilatator muscle, and it causes mydriasis, and inferior and superior tarsal muscle means that it has a very big part in lid retraction. And it has also a part in melanin pigmentation of the melanocytes in the superficial stroma of the iris. So it has a part in iris pigmentation. Yes. So Horner syndrome means the association of ptosis, pupillary miosis, and facial anhidrosis. And in children, when this syndrome begins very early, you can have an iris heterochromia, and the lids are droopy or drusen lids. Voilà. This syndrome may be isolated, or it may be associated with other clinical signs, and the main thing you have to remember is that it may reveal very severe underlying disease, which means that when you have a Horner syndrome, unless you have a very specific and very obvious cause, you have to make an imaging to know what's happening. So just a little word about upper lid motion. The upper lid motion is due to two muscles. The biggest one is the levator palparis superior, which comes from the apex of the orbit and goes to the lid, and which is innervated by the third cranial nerve. And the other one is the superior tarsal muscle, which is called also the Muller muscle, and which depends on the sympathetic. And it goes from the inferior part of the tarsus to the superior margin of the tarsus. It is this little muscle you can see here, and when you open your eyes, there is a part of both muscles. To know where to find something when you have Horner syndrome, you have to know the oculosympathetic system anatomy, and it is a 3-neuron system with 2 synapses. The first neuron is called central neuron. The first one is the second neuron, and in between them there is a synapse, and it is a preganglionic neuron, and the third neuron is called postganglionic neuron. And the big landmark are the floor of the third ventricle and the hypothalamus, the brainstem, the spinal cord, and some ganglion that are belonging to the sympathetic chain, and that the inferior, middle cervical, and superior cervical ganglion. The inferior is at the level of C7. The middle ganglion is at the level of the hyoid bone, and the superior one is just at the level of the carotid bifurcation. And when we draw this system, the first neuron comes from the carpus and cradle center in the floor of the third ventricle. It goes at the back of the brainstem with the radicular formation, and it goes down at the posterior part of the spinal cord to the cilio-spinal center, which we call in French Budge-Waller center, but every country has the name. And there is the second neuron here, which goes directly through the three ganglions, or which can make an arch under the subclavian artery before going to the end of this second path. And the third path comes from the superior cervical ganglion. It goes around the carotid artery, the internal carotid artery, goes in the skull, goes in the carinous sinus, and goes through the superior orbital fissure to the orbit and to the eye. And it is with the 5th and with the 6th cranial nerves. It goes through the ciliary ganglion, and at the end show the innervation of the pupillary dilatator and the superior tarsal muscle. So you see that when you have a Horner syndrome, you have to see the brain, the cervical spine, the neck, and the orbit. So it's a complicated way. another view from the CT scan where you see very well the relationship in between the brachial plexus roots and this sympathetic pathway. When you make transverse slices on CT scan, you can see easily this sympathetic pathway, which is just in front of the vertebra, each side of the vertebra at the different levels. And you can easily see the inferior ganglion at the level of the thyroid. You see the inferior ganglion, and the superior ganglion at the hyoid level. So it's rather simple to know where to find the lesion. It's in front of the vertebra, each side. So a little bit about the pupil. The pupil is a hole, and this hole is limited by the iris, which is a muscle, which is around at the anterior part of the ocular bulb, and behind the iris is the lens. And as you see, there are two different muscles around the iris. One is the constrictor of the iris, and it depends on the parasympathetic fibers, and one is the dilatator of the iris and depends on the sympathetic system, and both systems are acting to open or close the iris depending on the light. And normally this is the eyes. When you are in the night, when the light is low, you open your iris, you open the lens to the iris to allow more light to enter the eye, and when there is sun, you shrink the iris, it is a meiosis, to avoid too much light entering the eye. And generally, Horner syndrome is unilateral, and so you are going to have an anisocoria, which can be physiological and which is an asymmetry of the two pupils. The difference is more than 0.4 millimeters. It can be physiological, but of course it can be a meiosis, and the meiosis is due to Horner syndrome, or a mydriasis, which is due either to a parasympathetic lesion and oculomotor nerve pathway, or to deep tonic pupil. And you'll see sometimes this tonic pupil in young women. It's benignant. It is in fact a lazy pupil. The problem when you have an anisocoria is which side is pathological. Is it the smallest or is it the biggest? And so we have some tricks to find which side is pathological. This is an anisocoria. Is it a mydriasis or is it a meiosis? You put the patient in the dark. Normally in the dark the pupils are opening. So this side is opening, this side is not opening, nothing happens. You put now the patient in the light. This pupil normally decreases in size, this pupil doesn't move. So up to you, is it a sympathetic problem or a parasympathetic problem? Exactly, it's a sympathetic problem. This is a meiosis, so we have a Horner syndrome. We have to find the lesion along the path I described you. Now we have another anisocoria. Is it a mydriasis or is it a meiosis? We do exactly the same thing. We put the patient in the dark. In the dark, normally the normal pupil will enlarge, and in the light it will normally decrease. This pupil doesn't move. This pupil is pathological. It is a mydriasis. And so when the patient comes, sometimes he says, the ophthalmologist put me in the light, in the dark. That's just to know which side is pathological, and it's very efficient. Now, just pharmacological testing, they will help us to confirm the diagnosis of Horner, and the ophthalmologists use two types of collier, cocaine or apracodidine, which makes the same effect and confirms the diagnosis of sympathetic lesion, and hydroxyamphetamine, which give the location of the lesion. When the test with hydroxyamphetamine is positive, it is a postganglionic lesion. I will just explain what. Normally, the normal sympathetic nerve ending is full of norepinephrine, and the norepinephrine acts as a simulator for the iris dilatation. So the norepinephrine is just released. It stimulates the receptors and the iris dilatation comes, and after it is reuptake. This is normal. When you put cocaine, it blocks the reuptake, and what happens? There is a lot of norepinephrine in the synaptic groove, and so the dilatation is exaggerated, and there is a big mydriasis. So this is the acting of normal, when the sympathetic nerve is normal, there is a mydriasis when you put cocaine in the eye. But when you have an injured sympathetic pathway, the norepinephrine is very poor. There is not a lot of norepinephrine. So when you put cocaine, even if you put a lot of cocaine, there is so little norepinephrine in the synapse that it has no effect, and so the pupillary dilatation is very discrete. And when you have a meiosis and you put cocaine and there is no mydriasis, it means it is a Horner syndrome. It's quite simple. And so the normal pupil after cocaine dilates, the injured sympathetic side after cocaine, it remains about the same. And for the hydroxyamphetamine, it's different. It's in charge of the release of the norepinephrine, and so when there is a postganglionic lesion, the effect is very poor because there is no epinephrine. Though when the lesion is preganglionic, it has a correct effect and it dilates because it releases norepinephrine, which stimulates the dilatator. But when the lesion is on the third neuron, the norepinephrine there is no more norepinephrine, and there is no mydriasis. And so with the two colors, we have the confirmation of the Horner syndrome, and sometimes ophthalmologists can say, look at the lesion, it's rather the spinal cord, it's rather the second neuron, or it's around the carotid. And so I will now show you some example of those lesions just to show you where in the anatomic pathway you can find them. First, of course, it's at the hypothalamus to T2 level, and of course, when you suspect a lesion either of the brain of the spinal cord, the best way to see it is to perform an MRI. And the brain MRI can see this lesion of the posterior aspect of the hypothalamus, which can provoke Horner syndrome, or this vascular lesion, which is a stroke, a recent stroke, in the territory of the cerebral posterior artery. And you can see at the same time the posterior thalamus lesion, and also an occipital lesion. And it can be also in the spinal cord. Look at this very well, because there will be question at the end of my talk about the thing that you can see on this spinal cord anatomy. And one of the brainstem anatomy, and one of the other stroke that can provoke Horner syndrome is the lesion of this part, which is the stroke in the Pica territory, which gives the Wallenberg syndrome. And you know, in this syndrome, that is you find crossed findings. It means that there are signs on the side of the lesion and sign on the other side of the lesion, and it is a sudden onset of severe vertigo, nausea, vomiting due to the 8th nerve lesion. Stabbing pain, and after facial loss of pain and temperature sensation because of the lesion of the 5th nerve. There is a cerebral syndrome because of the lesion of the cerebral fibers, hoarseness, dysphonia, dysphagia, and dysarthria due to the 10th and 9th nucleus lesion. And there is a contralateral loss of pain and temperature sensation due to the spinothalamic tract lesion, and of course Horner syndrome. And the sympathetic is just at the back of the brainstem. And this is an example of this stroke, which was in this patient due to a vertebral artery dissection. And you see very well the little spot with the low ADC corresponding to the recent infarct, with on the MRI the thin and irregular vertebral artery, this aspect being due to the dissection. So in Horner syndrome, you understand why, in this Van den Berg syndrome, you understand why there is a Horner syndrome. When you look at the spinal cord now, the sympathetic is located at the middle, lateral middle of the spinal cord, and so in fact, any lesion of the spinal cord could potentially provoke a Horner syndrome, and which is not always seen in the clinic. But anyway, Syringomyelia has been described with Horner syndrome, such as multiple sclerosis, and you see that the sympathetic being there, it is very probable it could cause a Horner syndrome, even if it's not very frequent. In fact, it can be due to the Vick disease, and in this case, it's more the edema than the lesion itself that cause the Horner syndrome. It can be due to spinal cord tumor, and I choose to show you this hemangioblastoma because you see the lesion is very small, but the edema is extensive, and so can provoke lesions at several levels of the spinal cord, and of course anything that you can imagine that can hurt the spinal cord. The second neuron, predominantly second, from T2 to the level of the carotid bifurcation, is injured, especially in post-surgery or traumatism, and it is the most frequent cause of Horner syndrome. So when you have a patient that has a Horner syndrome and that has been operated from the thyroid, it's not necessary to perform imaging. We know that during the surgery, probably the surgeon hurt the sympathetic. The second lesion that can be cause of Horner syndrome in this area is all the lesions that are on the apex, the pulmonary apex, especially the cancer, the lung cancer, that can grow at the lung apex and extend to the roots of the brachial plexus and give a Horner syndrome, such as this case which has been given by Marie-Pierre Revel, who is very good at thorax. And this is a upper lung lesion which goes, you see, under the subclavian artery, exactly when the Vieuxens arch goes, and destroy the ribs, and it explains very well why this cancer has been discovered, because the patient has a Horner syndrome. The tumor of the sympathetic system are rather rare in adults. You can find schwannoma especially, but the main tumor of the sympathetic system that will give Horner syndrome is the neuroblastoma in children. And so when you have an Horner syndrome in a little kid, you have to think of neuroblastoma. It's really important. It's the tumor of the neural crest origin, and it is mostly occult at the first time, and when you discover the lesion, often there are metastases of the lung, there are nodes, and there are cutaneous metastases in more than 50% of the patients. That's the problem. And the diagnosis, of course, is clinical if there is an abdominal mass. It can be guessed because the baby has an iris heterochromia, and when there is an heterochromia, you have to look for a neuroblastoma, and of course because of the biology and my biologic scan. And this is an example of a neuroblastoma in a 5-month-old boy with this thoracic opacity, and the lesion is huge. It is exactly on the path of the sympathetic, as we have seen before, and there are already cutaneous metastases in this boy, and also axillary nodes. The chemotherapy is, of course, rather efficient, and this is the result of the chemotherapy before a complementary surgery to remove this little remnant area. Just a word about congenital Horner. It can be due to this tumor, but of course it can be a trauma. It can be an abnormality of internal carotid arteries, and it has been described with agenesis of the carotid. It can be due to ectomy thymus, which will compress the Horner system, and congenital varicella, and there are some familial cases. And on this area, there are also the nearby lesions, such as thyroid gland lesion, and it is more often a goiter than a malignancy, just because goiters are more frequent than malignancy. It can be a paraganglioma, and some very rare paraganglia may arise from the sympathetic system. It can be a first thoracic nerve lesions, any lesion like compression tumors, or a mediastinal tumor. So everything that goes around this area, from the pulmonary apex to the bifurcation of the carotid, can provoke Horner syndrome, like in this patient with this very huge goiter and who had also Horner syndrome. And at last, the postganglionic lesion, it's the lesion of the third neuron from the carotid bifurcation to the orbit, and the first cause is an abnormality of the internal carotid, and the first lesion of this internal carotid is the dissection. And it's what we see the most. It's the patient that comes, he has a Horner syndrome, and the question is it a carotid dissection or not? And you know that it is a serious problem because it needs a specific treatment and it can be complicated. It may present as a cluster headache, and there is often a story of traumatism, and it is painful. The MRI up to me is better than CT scan or Doppler, because the dissection is of a very low, just under the skull base, and it can be missed easily by the Doppler, and the CT scan can't make, as well as the MRI, the brain checkup. This is an example of carotid dissection with the hematoma, which is very well seen on T1 with fat suppression sequences, which should be used at first just to get where is the hematoma, and which is also very well seen on this MRA, which shows at the same time the thinning of the carotid and a complication, which is a fake aneurysm. And of course, when you study this dissection, one of the main things you have to find is if the dissection remains under the skull base or it goes in the brain, in the subarachnoid space, because in this case, as the risk of bleeding after anticoagulation is high, the neurologist will not use anticoagulation. And of course, you have to complete by a brain MRI to find complications such as a stroke. All the other lesions of the internal carotid are more rare, but can provoke also Horner disease. Even carotid agenesia, as we have seen, is the congenital Horner syndrome. And all the nearby lesions can, of course, provoke Horner syndrome, such as paraganglioma, adenopathy, schwannoma. This is an example of paraganglioma. And just remember that the paraganglioma has an arterial supply, and the best way to see a paraganglioma, to confirm the diagnosis, is to perform a dynamic MRI, which show at the same time as the opacification of the arteries, the opacification of the lesion. And this paraganglioma is just on the way of the sympathetic path. Of course, when we go in the brain, it's all that is around the sinus, the cavernous sinus. In the cavernous sinus, because the sympathetic goes through the cavernous sinus, can be anything you can find in the cavernous sinus. And also all the lesions that are around that can invade the cavernous sinus, such as nasopharyngeal or pituitary tumor or skull-based tumor. All the orbital lesion can potentially give a Horner syndrome. And this is an example of the pituitary macroedema, which goes in the right cavernous sinus and which gives Horner syndrome, or a nasopharyngeal adenoid cystic carcinoma, which goes from the nasopharyngeal area to the cavernous sinus and provokes a Horner syndrome. So, how to image a Horner syndrome when it's a first or third order lesion, head and neck MRI? When it's a second outdoor lesion, it's more a CT scan because as you saw, lung cancer has a big part in the etiology. So a lot of authors, when there is no cause, nothing, and you want to study this Horner syndrome, advise to perform spinal cord MRI, brain MRI, and neck and upper lung CT scan to be sure to miss nothing. And who is going to undergo this imaging? Of course, not the patient that have an obvious cause, that like the patient that has been operated, but the patient that have a Horner syndrome that appeared without obvious cause, because it can reveal this life-threatening disease. Often it's normal, but sometimes you'll find a neuroblastoma in the kids, carotid dissection, lung cancer, skull bone neoplasm, or stroke. And so Horner syndrome is not a light disease, it is a heavy disease, and when you have to study it, and don't refuse the patient because sometimes it can save his life. Thank you very much.